All right. So, hi everyone. Good evening. Hope everyone is doing well. And I welcome you to this ICS webinar on a very interesting topic and something, which we've been hearing about quite a lot because the World Asthma Day was recently around the corner. And this year it was a very interesting theme. It was about educating everyone. It was not just about educating our patients, it was also about educating ourselves as to what we can do better. So today's webinar is on difficult asthma, difficult to control asthma. Multiple names, multiple confusions. The crux of the matter remains that it is difficult yet very, very common. So today we are going to talk about all the aspects, right from picking it up, from managing it, from following it up, because difficult asthma is something that we as pulmonologists are going to see day in and day out in our OPDs, IPDs, and something very, very important. So before we start, I would like to take this opportunity to thank the Indian Chess Society, Dr. Amita Nene, Rajadhar Sir, and Dr. Sandeep Salvi for all the great work that they do. Our partners, Lupin, for organizing the whole thing. Thank you so much, everyone. And, I'll introduce the panel later, but the talk on difficult asthma would be given by Dr. Rajesh. Now, Dr. Rajesh V needs no introduction. He's someone I'm very jealous of because he did his post-graduation from Goa Medical College. Now, who goes to Goa to do their MDs? No, you have to be really lucky to be there. So Rajesh needs no introduction to the pulmonology fraternity of our country. Rajesh is the head of Rajagiri Institute at Kochi, and multiple laurels to his credit. He's been awarded with multiple gold medals, the Santosham Gold Medal for having the highest marks in DNB respiratory medicine, while all of us were struggling to pass. His was the organizer of the fantastic Kochi NAPCON, multiple talks, national, international. We keep running into him at conferences and talks. So I think we could have not had anyone better to do justice to this topic. So all yours, Rajesh. Please go ahead and tell us about difficult asthma before we start the panel discussion. So over to Rajesh.
Thanks a lot, Dr. Arjun. Again, a pleasure sharing an academic event with you, something that we have been doing for the last decade, I would say. And again, a lot of laurels to the ICS scientific team, Sandeep sir, Dr. Rajadhar, and none other than Dr. Amita madam, who has been the backbone of scientific support for ICS. And she has been instrumental in ensuring that the scientific webinars have been moving on flawless with a huge degree of attendance and a huge degree of academic content to it. So thanks a lot, ma'am, for anchoring it so well and giving us the opportunity for this particular webinar series. So I will just share my slides. I hope it's visible.
Yes, sir. Please proceed.
Okay. So the next 20 or 25 minutes, I will try to share with you systematic evaluation and management of the so-called difficult asthma. And what I would be trying to do is I will try to share some definitions of uncontrolled, difficult, severe asthma, etc., which, of course, Dr. Arjun said they are all confusing terms and poorly defined terms. And how do we systematically evaluate a difficult asthma, difficult to treat asthma, a systemic evaluation checklist? Some words on the phenotypes and the tools of how we can phenotype a true severe asthma, therapeutic interventions, including the treatable traits and the biologics, and a summary of what we are up to. To start off with a couple of disclaimers that I will stress on real-world challenges rather than hardcore evidences, and I will utilize some of real-life case scenarios for substantiating my point. Now, as I took up this particular talk, I realized that attempts at defining difficult to treat asthma is also pretty difficult. So difficult to treat asthma is also difficult to define asthma till around 2013 when the ATS-ERS consensus came, because prior to that, there were a lot of terms like uncontrolled asthma, difficult asthma, severe asthma, therapy-resistant asthma, so on and so forth. Loose, ambiguous, lack of precise definition, and used interchangeably in colloquial language as well as in scientific forums. So there was a significant overlap. And before I move to the difficult to treat or the severe asthma, I will just try to share with you what exactly is uncontrolled asthma. So any asthma where there is poor symptom control or frequent exacerbations or serious exacerbations or persistent airflow limitation by spirometry, any even the presence of a single criterion makes asthma, by definition, makes asthma an uncontrolled entity. So the poor symptom control, because there are poor perceivers of treatment, poor perceivers of symptoms across the population. There have been various scorings, including the ACQ and ACT, etc. Exacerbations more than or equal to 2 exacerbations in the last year requiring systemic steroids is termed as a frequent exacerbation, severe exacerbation. Any hospitalization, ICU stay, etc. is defined as serious exacerbation, and any FEV1 less than 80% of predicted with the FEV1 FEVC ratio that is less than the lower limit of normal is persistent airflow limitation. So if you see this uncontrolled asthma definition, then the asthma can be uncontrolled due to multiple things. It can be due to the fact that the patient is not taking treatment or is given a suboptimal quanta of treatment, which makes it an untreated severe asthma. Or it can be a difficult to treat asthma because there are some comorbidities and other things which is not addressed, which makes asthma a difficult to treat state. Or it can be a true severe asthma in the sense it needs a very high intensity of treatment even after collecting all the collectible factors. Again, asthma severity and asthma control are two different terms. Asthma severity is actually a measure of the intensity of treatment that is needed to control asthma. How large a dose of drugs or a group of drugs is needed to control asthma. That is the asthma severity. Versus asthma control, which I said that is the extent to which the clinical manifestations or even the inflammatory manifestations are controlled by the existing treatment. So, for qualifying to the definition of severe asthma, the ATS ERS 2013 consensus states that the prerequisites are the diagnosis of asthma should be confirmed. It should not be an asthma mimic. The comorbidities should be adequately addressed. The patient should be requiring treatment with a high dose ICS plus a second controller or even systemic steroids. And if asthma is remaining uncontrolled despite these agents, then we call it a severe asthma, and preferably such cases should be managed by an asthma expert for at least a period of 3 months before we label it as a severe asthma. So with this preamble, we will just move to how we evaluate and treat a case of difficult to treat asthma. Again, I start off with a case scenario, real life case scenario. This is a 44-year-old gentleman who came to me from Kolkata. He had an adult onset asthma. The diagnosis was pretty secure with the consistent history, normal chest radiograph, classic spirometry, etc., etc. So he had frequent exacerbations over the last 8 months when he was seeing me. I did a step-by-step escalation of therapy. I went up to high-dose ICS, LABA, and all those things, and even was planning for high-intensity treatment, including the biologics. So at this time, I thought probably I need to sit with him, take a very, very focused history, recheck the inhaler technique once again, and all those things. So one more poke into the history at this juncture made me realize that he is taking his medications during exacerbations and maybe a couple of weeks thereafter, and then he stops. When his asthma gets controlled, he stops the medications. And this required multiple pokings to come out from that particular patient. So the moral of the story is that if someone is non-compliant to medications, then the asthma is never going to be controlled. So that is one of the causes of difficult to treat asthma. So drugs do not act in those who fail to take them. That's a very, very simple terminology. So we need to ensure compliance before we label as a severe asthma. And across the globe, a substantial chunk of asthmatics are non-compliant to treatment because asthma is a easily controllable disease. The vast majority of asthmatics are easily controllable with a small quanta of treatment like an ICS LABA combination plus or minus a montelukast or whatever be that. So once the asthma control is there, many of them start discontinuing the drug. So this leads to non-compliance and recurrent exacerbations. The compliance rate, even in the best of countries, is around 20 to 30%. And there are multiple reasons for that, right from ignorance to concern of long-term side effects, the perceived risk of dependence, the concerns about the harm, unpleasant effects, etc., etc. So ensuring compliance is very important. The second case scenario occurred at the time when I was a postgraduate student. So this is a 21-year-old lady with mild persistent asthma. She was prescribed a combination of formoterol budesonide MDI with spacer, 1 puff BD, but she had inadequate response over the next 2 to 3 months with daily symptoms, frequent ED visits, loss of work days, etc. And then at this point of time, the inhaler technique was cross-checked. And imagine what we found. This lady was just locking her up in her study room. She was just spraying the inhaler into the room, the atmosphere of the room, and just she stood in the room for around 10 to 15 minutes and took the breaths from that particular closed room. So the next step is that the ensure correct inhaler technique, because unlike a pill or unlike an injection, the systemic absorption or whatever the absorption or the availability at the site of action is not guaranteed with an inhaler unless the inhaler technique is correct. So we have a lot of fancy devices that are available in the market. So each particular industry comes and tells that their product is best. So ultimately, the most important thing is that we need to be clear about what device we are using. It should be a shared decision. The doctor as well as the patient should be very clear as to how that particular prescribed device has to be used correctly, and that has to be periodically ensured as well as supervised. The third case is a 22-year-old dentistry student with the mild baseline asthma right from childhood, family history of atopy. And the most important thing is she is allergic to dental filling material. So she's as a profession and she has something in her profession to which she is substantially allergic to. So this causes the dental filling material exposure causes sudden severe exacerbations after her practical sessions. But she is very passionate about the profession. She is not willing to give up. She has one more year remaining, and after this, she was saying that she was planning to shift to a non-clinical specialization in dentistry where she need not have a contact with her dental filling material. So she wants to somehow get over that particular period and wait for the course to get over. So theoretically speaking, this is an uncontrolled or difficult to treat asthma, but in a very definitive or definition-wise sense, this is not a severe asthma because she is not avoiding her triggers. So avoidance of triggers is very important when it comes to asthma control. It can be occupational exposures or outdoor exposures like dust, smoke, fungal spores, etc., pets or mites inside the home, smoking, repeated infections, drugs, etc., etc. So if you are treating the patient and you are not avoiding the triggers, then it's like pouring water into a bucket with multiple holes. It's not going to have any effect. So avoidance of trigger is the next important thing in dealing with the case of difficult to treat asthma. Then this is the fourth case. This is a 22-year-old nursing student with poorly controlled asthma. She actually was studying in Andhra Pradesh and here she had her home in Kerala. She had uncontrolled asthma, but the clinical evaluation revealed that she had headache, nasal discharge, belching, etc., etc. So probably she has a sinusitis, upper airway component to it, plus or minus a gastroesophageal reflex. So she was evaluated by an ENT surgeon. There was bilateral maxillary sinusitis, bilateral FES was done. She was put on intranasal steroids, and empirically proton pump inhibitors was also given, which led to very good control of her asthma. So treat comorbidities that can worsen asthma control, like the upper airway disease. Sometimes vocal cord dysfunction can be mimic obesity, OSA, hyperventilation syndromes, etc., etc. Gastroesophageal reflex, hormonal influences, psychological factors, all those things need to be taken care of before we really label a patient as having a severe asthma. The fifth case is a 50-year-old lady with adult onset asthma, menorrhagia. She has a fibroid uterus. She is being planned for hysterectomy. And at that particular stage, she was referred to the pulmonologist as a case of poorly controlled asthma because she had progressive shortness of breath for the last 2 months and a noisy breathing. Now, when she was, this happened when I was in Amrita Institute. So when she was being examined by a resident in Amrita Institute, when the neck was palpated for any evidence of lymph nodes, she has sudden worsening of shortness of breath with stridor. I don't know whether this X-ray is clear, but at least in the CT, what we can see is there is a airway tumor below the vocal cords, and that was actually causing a stridor, which was being misinterpreted as wheeze by many of the practicing clinicians. So, ideally, the first step of difficult asthma should be to roll out asthma mimics and get a secure diagnosis of asthma. But I have put this as the step number 5 because the asthma mimics are much less common than a poor inhaler technique or non-comprehensive. So that's why I have put it as a step 5. But ideally, it should be the first step. Roll out asthma mimics before we really start labeling as a difficult to treat asthma. So it can be a COPD or a bronchiectasis, left ventricular dysfunction or left ventricular failure also causes wheezing. Vocal cord dysfunction can cause noisy breathing, airway lesions, foreign body aspiration in children, etc., etc. But most of these things can be tackled and evaluated by a focused history, physical examination, spirometry, ECG, echo, ENT examination, CT chest, etc. So the CT may be revealing many things that the chest X-ray does not reveal. So before we really go to the higher end treatment for a severe asthma, we always need to do a CT test. So the cause of difficult asthma in the vast majority are non-compliance to medications, incorrect inhaler technique, and persistent triggering factors. In a small number of cases, it can be a wrong diagnosis or a comorbidity that can worsen asthma, which not adequately addressed. And if these things are taken care of, and then we administer the proper quanta of treatment. Proper quanta of treatment, when I say, I mean maybe a moderate to high dose of ICS LABA combination, plus or minus a anti-muscarinic inhaler, plus a montelukast, and at least in our practice setup, a sustained release theophylline also. Despite all these things, the patient is still having uncontrolled asthma. That is the time when I start thinking of a severe asthma and go ahead for phenotypic evaluation and individualized care. Phenotyping is very important at this particular step of asthma care. So we can do simple phenotypings based on the age, family history, etc., where we get a history of atopy. The blood parameters like in the peripheral blood eosinophilia and IgE, serum IgE levels, a skin prick test for various allergens, induced sputum eosinophils, phenol levels, etc., etc. And each has its own advantage and disadvantages. But in practical terminologies, we usually go ahead with the total IgE as well as serum or sputum, induced sputum eosinophils. Now, there are some limitations of the current treatment approaches for asthma. I'm just going to, from the basic stuff, I'm slightly going to a slightly higher stuff. So the current asthma treatment approach by GINA is a stepwise escalation of the intensity of treatment to achieve optimal asthma control. This works very well in the majority of asthmatics, but there are some limitations, including the fact that this particular model believes on a one-size-fits-all concept. So that may not be the case because we know that asthma is a heterogeneous disease and each patient with asthma is unique and slightly different from others. And again, the step-up model takes much more time to reach asthma control than a higher-end, phenotypic-based treatment. Some of the individual treatment targets may be missed, and this approach actually focuses on current asthma control, but not the future exacerbation risks. So there may be heterogeneity in asthma patients. So heterogeneous approach to treatment also may be required, adhering to the broad guidelines as a baseline. So this has brought us to the so-called treatable traits approach, which is very important, at least in severe and more complex forms of disease. So this is a direct offshoot of the concept of precision medicine, which aims to apply personalized strategies and medicine to each individual in an attempt to improve outcomes. Treatable traits are defined as observable and treatable features of the disease that explain or account for differences between individuals with the same disease and they are associated with meaningful outcomes. So the key components of a treatable trait are that they are observable, they should be measurable, they should be treatable, and when they are treated, they should be outcome modifying. The treatable traits in asthma are broadly divided into three domains: the pulmonary traits, the behavioral and lifestyle traits, and the extrapulmonary traits. And some of the pulmonary domain include eosinophilic inflammation, emphysema, hypoxemia, bronchiectasis, etc., which have specific therapeutic approaches. The extrapulmonary targets include obesity, impaired exercise tolerance, GERD, etc. Lifestyle modifications like smoking, poor inhaler technique, non-adherence, etc. So these treatable traits need to be looked into in all cases of difficult to treat and severe asthma, and they have to be targeted with the appropriate correct approach. And finally, the high-end treatment for the severe asthma includes various biologic agents as well as bronchial thermoplasty. I will just touch upon biologic agents for a few minutes before I wind up. So in India, we have three biologics that are right now available. So the atopic asthma would qualify for anti-IgE treatment. The eosinophilic asthma qualify for anti-interleukin-5 treatment. A substantial chunk of them have overlapping phenotypes, so they will be candidates for both. Neutrophilic asthma, we have agents that are coming up, which are actually FDA approved and available in the Western world. Probably they might be available in India also in the next 1 or 2 years. And this is a slide which shows the various agents that have been FDA approved. We have omalizumab, benralizumab, and mepolizumab that are available and marketed in India. In the absence of head-to-head trials, comparison of efficacy is difficult. All are effective, but each has its own unique advantages and disadvantages. Omalizumab has been studied in multiple trials, and the pooled data shows that there has been almost 40% exacerbation rates in asthma upon using omalizumab. The advantages of omalizumab is that it has the largest body of experience because it has been there for a couple of decades now. It has a decent efficacy on exacerbation reduction, and it's also effective in other atopic states. It has a very good data on pediatric population also. It has an Indian biosimilar molecule, so that way the cost of treatment is also decreased. The problem with that is there is a broad exclusion criteria for use, especially based on the IG values. The dose and frequency calculation can be cumbersome, and the reconstitution also can be labor intensive in a very difficult and in a very busy OPD. Mepolizumab has been evaluated in multiple trials, including the DREAM, MENSA, MASCA, etc., etc. The pooled reduction of exacerbations to the tune of almost 60%, and exacerbations needing hospitalizations are decreased by around 70%. And there has been even studies which shows that mepolizumab is effective in omalizumab failed cases. So the advantages of mepolizumab is that it has a decent real-world experience, has a powerful effect in it is useful in other conditions of hypereosinophilia like HES and the Church syndrome. It has data in failed omalizumab treatment also. The disadvantages are that failures are uncommon, but again they are reported. It has a subtotal eosinophilic depletion as compared to benralizumab, and there is a small risk of helminthic infections. Benralizumab is the latest of those kits, and it has the advantage that it improves almost all aspects of asthma control. It has the fastest response in asthma exacerbations. By the second dose, almost the patient has started feeling the improvement. In the continuation phase, it can be dosed once in 8 weeks, and it probably gives the highest magnitude of benefits with regard to exacerbation reduction, oral corticosteroid sparing, and improvement in lung function. So, the various factors that we should use include the patient age, the desired outcomes, the ease and frequency of administration, economic considerations, etc., etc. And before we really start, we should discuss with the patient as to what they expect from this treatment. So there should be a predefined individual treatment objectives and a shared decision making between the patient and the clinician. And after 3 to 5 months of use, we should have a global evaluation of treatment effectiveness, whether the treatment is giving the desired benefits to the patient. If not, there is no point in continuing. If the patient is getting the benefits, then probably continue. And there is also an option of switching from anti-IgE to anti-interleukin 5 in the case of shared phenotypes. Finally, if a patient with asthma has uncontrolled asthma or frequent exacerbation, first step is that we should reassess the asthma diagnosis, whether we are dealing with any asthma mimic. If not, look at the inhaler compliance, check the inhaler techniques, ensure that the patient is compliant as well as taking the inhaler properly. Look for persistent triggering factors which the patient is exposed to and correct it. Look for comorbidities that can worsen asthma control and tackle them. Give the proper quanta of treatment, usually a high-dose ICS-LABA combination plus a leukotriene receptor antagonist plus the sustained release theophylline plus an antimuscarinic agent, sometimes even a maintenance oral corticosteroids. Now, with the advent of biologics, that is not recommended as the first step. And look at specific phenotypes with therapeutic implications and phenotype of the patient for IN treatment like biologic agents. Thanks a lot.
Great work, Dr. Rajesh, summing it up so nicely, so so easily, and I think that is what makes it all the more assimilable, because whenever you talk about severe asthma, difficult asthma, as you very rightly said, there's a lot of confusion. The definition is not clear. So many definitions, so many words, and people tend to confuse between severe asthma, difficult asthma. So I think the panel discussion that we'll now undertake is going to address a lot of these questions, right? And there are so many questions that people have, practical questions which are related to asthma management. So before I introduce the panel, can I please have the slides on? The technical team to please project the slides. Yes. So the first panelist, we have 4 great panelists with us today. Dr. C. Ravindran, sir, needs no introduction. Teacher of teachers, has taught all of us, senior consultant, and was the head and the principal of Government Medical College, Calicut. ICS South Zone member and someone, who's been there all along, and a member of ICS, has been the chairman of the South Council South Zone of the Indian Chess Society. Pleasure having you here, sir. We are looking forward to discussing this topic with you. Next is Dr. Parul. Dr. Parul Vadgama is the professor and head of the Department of TB and Chest at Government Medical College, Surat. Multiple laurels to her credit, number of presentations, papers. Always a pleasure to listen to her and interact with her. Thank you so much, ma'am, for joining us here today. Really looking forward to this, question and answer session with you. Next, we have with us Dr. Saibal Moitra, please. So Dr. Saibal is from Kolkata. Sir is an adjunct professor and a senior consultant. He is associated with the Apollo Multispeciality Hospitals in Kolkata and is also a part of the famous allergy immunology program, which is run by CMC Vellore. Has an amazing H index and has multiple grants and intramural, extramural projects. Pleasure to have you here, sir, today with us. Last but not the least, my dear friend Indu. Indu practices in Mumbai, needs no introduction, has been there around for so many years. Always a pleasure interacting with us. Has a number of awards and laurels to her credit. And I think having Indu here today is great, because we're going to have a very good discussion with you, Indu, today. So can we stop screen sharing, please? Yeah. So
Can I just have the screen of Dr. Arjun, because we should have done this initially, but better late than never. So Arjun, I think you are already halfway through, but then it's my pleasure and privilege to introduce Dr. Arjun Khanna, our moderator, who has been, I would say, an academic brand name in our country and even beyond. The way he anchors any discussions, any clinical discussions, as well as any academic discussions, is amazing. And I recently had the pleasure and privilege of witnessing how he anchored the Harvard meeting organized by Mankind in three major cities of India, and it was really fabulous. So we are very fortunate to have you with us, Dr. Arjun. So just to have a customary introduction, he's the head of the department and senior consultant of pulmonary medicine at Amrita School of Medicine, Faridabad, perhaps the largest private hospital complex in India. He's a fellow of the Asia Pacific Society of Respirology. He's very trained and very, very skilled interventional pulmonologist, and he did that from Thailand. He's a former assistant professor of the prestigious All India Institute, New Delhi. He's a global rising star in pulmonary medicine 2019, the Lung Health Council Nice France Award. More than 100 publications as well as book chapters, and 500 plus, that's huge, invited talks and lectures. His areas of interest obviously are, one of them is the severe asthma and airway disease, pulmonary rehabilitation, end-of-life care, and palliation. So,
thanks.
Sorry for that interruption, Dr. Arjun, and please continue.
Thank you, Rajesh. Sure. So, let's start this panel. I've already got a lot of questions that are pouring in, so I'll try to incorporate as many questions as possible, because number of logins we have right now is already above 1,500, and the number of questions that I have to keep track of is getting out of control now. So I'll try to do justice to whatever I can. So I request my panelists to be short, succinct, and to the point. And of course, we'll start with Professor Ravindra. Sir, the problem statement of difficult asthma, severe asthma in India, we know we have global figures. They talk about percentages and, ratios and proportions. Unfortunately, not too much data from India. So since you've been around for so long and, you've taught us all, what do you think is your perception? What do you think is the real figure of severe asthma and difficult asthma in our country?
Thank you, Dr. Arjun, for the nice introduction and for the wonderful question. Dr. Rajesh has already mentioned all these things, and we know that it's a confusion regarding difficult asthma, severe asthma, and the third one I like to include therapy-resistant asthma. All these three are interchangeably used in India. And when we go to the literature, what we see that therapy-resistant asthma is negligible in its occurrence, about 3 to 4%, and severe asthma 17%. But when we go to the difficult asthma part, it's a wide variability between countries. It starts from 17% to 70%. And we may be thinking that India has got the highest prevalence of this disease, but it is not like that. Even developed countries, high-income countries has got problems. The problem really may be different because we have poor accessibility, whereas the income country, there is strict regulations and difficult to reach all these problems are there. So when we look at this difficult control asthma, Japan has got about 60%. And Europe also has got almost similar value. India, actually, the value is not known to us, but we think that this will be almost similar because we have a lot of patient population not getting adequate treatment or not counseled properly. So the difficult control asthma will be a problem in India too. And what I see is that Dr. Rajesh has mentioned about the definitions, how we look at the difficult control asthma. But I want to tell you that this is in India, it is mainly due to the health seeking behavior and the misconception on inhalers, apart from ignorance, poor adherence, and wrong techniques. So both patients and doctors are responsible for these two things. So most of the difficult asthma patients can be controlled, or it is a reversible factor which produces difficult. But therapy-resistant asthma is really a separate entity which needs separate recognition and treatments. So we also have to look at the comorbidities. We know that many patients has got rhinosinusitis, which is not treated, but asthma is treated. It will not respond. Similarly, GRD is there, obesity is there, and smoking, another important one, whether it is active smoking.
I'll come to that, sir.
Or passive smoking, both will produce more problem to individuals, especially children with asthma. And we also have poor environment control, especially in certain areas where there is farming areas and all. Environmental control is poor, which leads to high number of severe asthma attacks. So these are the points which I want to highlight in this scenario.
All right, sir. So point very well taken. The percentage, the absolute load of difficult asthma in India is huge. So moving on to Dr. Parul. So, there is data from India. You need to unmute yourself, ma'am. There is data from India which tells us that asthma control in India is terrible. Studies saying that it is almost as bad as 0%. So why do you think the asthma control at ground zero in India is so bad? Why do we have so much of severe and poorly controlled asthma in our country?
Yeah. Right, Doctor. See, basically, the main reason which we all discuss or we can analyze about the zero control is that, see, basically at grassroots level, what we are finding out that there is lack of lot of awareness about the diagnostic methods, rather the strategies. There is lack of awareness when to refer to patient. Sometimes difficult asthma are diagnosed so late. Sometimes there is wrong prescription. Sometimes there is not a right referral, that and sometimes there is not a right prescription of the inhaled drugs. Sometimes the technique is wrong. Sometimes the teaching, or I would say the follow-up of the patient, is not properly correct. Sometimes there is lack of the diagnosis of the comorbidities, which also it's a hamper to the right management and correct management of the asthma. And above all, there are so many new things like air pollution, like vitamin D deficiency, like rhinitis, like increasing obesity. These all are the things which are like hidden of a iceberg, hidden part of the iceberg. So there are so many aspects at the grassroots level, or I would say at the zero level, where our health PHC, CHC, our medical officers, in fact BMS, BHMS who are practicing, they have to have the strategy and guidelines. They should know about the recent updates about diagnosis, about prescription. What is the first line of prescription? Oral bronchodilators are not first line of prescription. Inhaled myths and facts they have to know, and according to that, along with considering the comorbidities at the grassroots level, I think these things can be certainly handled. And above that, we also know that there is always an ethnic variance. There is always a socio-economic differentiation. There is always a belief differentiation in the society. There are some caste or some religions or some ethnics who have their own belief. So that also we need to address somewhere. But overall public awareness I think through media, through doctors. In fact, I would not say only public awareness. There is also lack of awareness in the medical fraternity about the right prescription, right diagnosis, right education to doctors as well as right education to patient. So I think this what we are doing is right education to doctors, but we also need to correct it at all PHC, CHC levels where the many doctors are BMS, BHMS doctors and they are handling the PHCs, and there we need to rightly educate them, rightly train them, and patient education is again has to be percolated rightly through the right doctor. So I
All right,
think that
ma'am.
is
Sure.
all about zero control. Yeah.
All right. So thank you, ma'am. Points very well noted. So moving on to, a very related question, Dr. Moitra. Uh, so we say that, asthma control is poor, and you look at the prescriptions that come to us. You and me, we both work at tertiary care centers, and you analyze the prescriptions which come to you with severe asthma, whether they've been given by a physician, a chest physician. All prescriptions would have a combination of montelukast with levocetrazine. All of them would have added, deriphyllin, doxyphylline, acebrophylline. There would be a PPI. There would be a multivitamin. There would be 5 other fancy drugs. But unfortunately, not too much emphasis again given on the inhaled medications. So what do you analyze of these prescription patterns that, a tertiary care center sees? And what is the message that we can give to a lot of young chest physicians who are here today? Does every prescription of asthma warrant montelukast with levocetrazine and doxyphylline and acebrophylline?
Thank you, Dr. Arjun. This is a very right point, a valid point that you have put up today. See, we find that the prescriptions are replete with all the drugs that you can see in the market. Okay. And polypharmacy is so common in our country. But the point is that why there is so much of polypharmacy when we're treating an asthma, when the disease can be very well treated by minimal drugs, inhaled corticosteroids with or without a long-acting beta agonists. The reason is that the amount of time which a doctor spends with his or her patients is very important. If they spend more time with their patient, try to understand the comorbidities, try to understand what is the level of the asthma and the control, and then teach the patient, educate the patient accordingly, and also teach them the good inhaler techniques. That goes a long, long way to control the asthma. But you see that the patients, the time they spend with their doctors is hardly, it may not be beyond 5 minutes. And within the 5 minutes, I don't think anyone can do any justice to the patient. So what happens is that the patient will keep on coming to them. The asthma is not controlled, and they go on adding medications, oral medications, just for the fact that to make the things more controlled. But that recently we know all the GINA, they have stated repeatedly, all the GINA guidelines, there is no need for all these fancy drugs. Okay, LTR is only an add-on. The doxyphylline, all those drugs have gone away. And this combination of a montelukast with another antihistamines is not a proper FDA-approved combination. This montelukast only if this exercise-induced bronchoconstriction of the patient is having some associated like allergic rhinitis, perineal, they may have add-on, but that's too, the intranasal steroids works the best. So it is very, very important that all the young chest physicians who have started their practice, they should basically harp on their interaction, time they spend with the patient, educate them, teach them the proper and need of the using inhalers and proper inhaler techniques, and then follow up them properly with the steps, when to step them down, when to step them up, with the proper monitoring and the control, maybe use of a peak flow meter or something like that, with a proper way and they should have a proper asthma action plan. The plan, if they go this, because this is what we get, what we try to find it out. And when these patients come to us and we just revise the entire thing and put them on the plan, and with the minimal drugs, they get control. So this is what is needed. So more time is with the patient.
Such a fantastic point, Dr. Moitra, because
Yeah.
most of this, this adds on to the financial burden and is actually not required. And, when you talk about biological therapy, we would say that, the patient is poor, cannot afford, biologics. If you look at the prescription patterns, we analyze this for COPD, the amount of money that a patient prescribes, patient pays for their COPD prescription was much higher than what they would, pay when they're actually hospitalized. So I think we need to be more rational with our prescriptions. So Indu, coming to you, when a resident or when a young physician is going to start practicing and working up these patients of asthma, which is difficult to control, or say severe asthma, the textbook list is exhaustive, 30 different investigations which you need to do. So what is Indu Bubna's prescription like in patients who have difficult to control asthma? What are the 5 or 10 most important investigation that Indu is going to do in all patients with difficult asthma? I don't want the textbook investigations, but a ready reckoner that these are the 5, 6 things that you must do and must not forget.
Sure. So I'll try to be as crisp as possible. So I think a thorough clinical history is most important in physical examination. That is the crux of the good clinical management, asthma management. Second, I think in my clinic, we have PFT. So we first go ahead, if the history is suggestive of asthma, we go for PFT and we look for the bronchodilator reversibility, which is 12% plus 200 ml. We look for that. And second, it also rules out COPD. So if there is a fixed airway obstruction, it rules out the comorbid COPD. Third, you ask for the blood test, which is CBC with a differential count. So you look for the eosinophils. If it is more than 500, you look for the parasites. You do a stool examination. You can do deworming. And if the eosinophils are more than 1500, you look for hypereosinophilia and then investigate for EGPA, the specific ANCA antibodies. So the second investigation would be total IgE to look for the atopy. So if it is more than 1000, I go for the Aspergillus fumigatus specific antibodies, which are IgE and IgG. This is the basic. And then, of course, the X-ray to rule out the other conditions. And if you're suspecting like a lot of phlegm is there, if the patient complains of a lot of phlegm, then you go for HRCT also. If you hear crackles or some other things, then the HRCT chest would rule out bronchiectasis, endobronchial TB, tracheomalacia, all that is ruled out in HRCT chest. If you're suspecting sinusitis, if the patient is complaining of allergic rhinitis or sinus problems, then you go for the CT PNS, okay, which will rule out, which is a very common treatable trait, which is chronic rhinosinusitis. Now, very common, which I see in my clinical practice, is the heart problems also. There could be a diastolic dysfunction, patient not having that much of crackles, but comes with pedal edema, comes with shortness of breath. So you go for an NT-proBNP and 2D echo evaluation. And of course, if there is joint pains or bone pains, then you go for the DEXA scan to rule out osteoporosis. So these are some investigations which ideally should be done if you're thinking of asthma diagnosis, and then accordingly work up further if you're thinking that the asthma is not under control. So you look for any modifiable risk factors, ask the patient whether he's a smoker, look if he's obese. If he's obese and having excessive, daytime sleepiness, you check the sleep studies also, look for the obstructive sleep apnea. And, then you optimize the treatment, check the inhaler technique. So your question was about severe asthma. So I would go a step further and probably look for the inhaler technique and the adherence. Many patients usually have the suboptimal adherence to the treatment. Many patients say that Chardin Dawali absolutely felt better, then stopped the treatment, or took it for 1 month and then stopped the treatment. So you have to check for the adherence, which is very, very common in the uncontrolled asthma group, which is difficult to treat. So besides that, the modifiable risk factors like exposure to the allergens or house dust mite or grass pollen, all this thing is very, very common. Look if the patient is on aspirin or having aspirin sensitivity, or the patient is on non-specific beta blockers. So look for the side effects. Many patients have this complaint of dryness of mouth or, shaking of the hands with the high dose. So they stop the treatment suddenly. So you look for the side effects. In our country, anxiety, depression, not in our country, but I would say the anxiety, depression part, the neuropsychiatric problems are also very, very common. So you look for that. And then, of course, optimize the management. So if the patient is on low to medium dose, you want me to go into the management part?
No, we'll come to that. We'll come to that. Just the investigation.
So I think these investigations and the history taking, I would do this.
Sure. So the investigations are exhaustive. I think the most important step, you said it right, one is good history and clinical examination, and the investigations would follow suit, no? Right. It would depend on what you see on clinical history and examination. Exactly. So we'll come to the details later, Indu, as we progress further. So the next question is for Rajesh. So Rajesh, where are you? So Rajesh, if you Google and if you ask what are the 3 biggest lies, that are said globally, the first biggest lie is I love you. The second is good to see you. And the third is I am fine. Okay. So when you ask any patient of asthma how they are doing, they say, I am fine. So we need to be very objective, This I am fine is what has led to asthma being so poor in our country. And I think one of the biggest challenges is that we don't use any asthma control or any kind of questionnaires in our clinical practice. So there are a lot of PGs here, Rajesh, today. So for their benefit, what are the common, questionnaires that are available to gauge asthma? Everyone wants to give a number these days. So if I have a patient with difficult asthma, I would want to gauge them, give them a number. So what are the common asthma questionnaires that are available to gauge the control of asthma in a patient? Which one do you think is most practical to be used in an Indian clinic?
Dr. Arjun, I will just start off with what I do. I'm not saying that that's the right way, but I would have to confess that I use it in a minority of my patients only. But then the usual scenarios when I am using it or rather forced to do it would be the severe asthmatics, where I really want to quantify it and convince the patient that they are not controlled. I would just highlight the APAIM study of Dr. Salvi, where the vast chunk of Indian patients are poor symptom perceivers, and they actually overestimate their level of asthma control. So coming to the question per se, the severity scores, I probably would go with ACT and ACQ7. Why? Because these are the two things that have been mentioned across the various asthma guidelines, including the GINA. They are self-reported by the patient. So if you have an assistant in your OPD, you just take a printout of that and hand it over to the patient. So when they are waiting, so by the time they come to your OPD room, they are there with that. So that's not something that I would do on a regular basis. As I said, prior to labeling as a severe asthma, prior to initiation of a biologic, or even for a dissertation or a publication purpose. These are the scenarios where I routinely look for the severity test. Otherwise, our routine clinical questions like, are you awakening in the night, or are you troubled with your routine work, or do you have any unscheduled hospitalized visits? Those stuff should be okay. Now, among those things, other than ACT and ACQ, we have other tests. We have a whole lot of separate severity questionnaires for the pediatric population. Even in the adult population, the assess is something that is coming out in the last 5 to 7 years. The last is something that is that's prevalent in some part of the geographic territory. But I probably adhere to ACT and ACQ. And by between them, I don't feel much difference in the sense both are administered to the patient in a reasonable manner. We have reasonably set cutoffs for uncontrolled asthma with both these questionnaires, like ACQ if it is more than 1.5, ACT less than 20, and we have also MCIDs, minimal clinically important differences to say that the patient is better or the treatment is working and all those stuff. So ACT and ACQ are the two things which I probably would adhere to when I am required to.
Very important, very, very important. And most of the residents would forget doing that in clinical practice. So very important to talk in numbers. These days, everyone talks in numbers, and it is very important that we as pulmonologists also gauge asthma control, nicely. So next question is for Ravindran sir. So, when you talk about asthma control, when you talk about OADs, a lot of these ICS LABA combinations have flooded the market. All kinds of steroids are available in combinations with all kinds of LABA. So if you look at the GINA guidelines, the step up, step down is all with formoterol, budesonide. And, most of these combinations are not talked about in the GINA guidelines. So are all these combinations equivalent to formoterol and budesonide? Can we step up, step down as, well as we would do in formoterol, budesonide? What is your take on these indigenous, combinations which are available in our country? How do we step them, step down? How do we rationale them? How do we place them vis-a-vis formoterol, budesonide?
Dr. Arjun, as per GINA guideline, we have only one combination for smart therapy, ICS, LABA in the form of budesonide and formoterol, and they recommend that. But as you said, we have a lot of combinations coming up, and when we look at this combination, I think most of the physicians, GP, are writing these new combinations. I don't know the rationale behind it, but when we look at this, when there are few studies looking at formoterol, that is bilateral combinations, we have some studies saying that it will be equivalent or better when compared to budesonide and formoterol combination. That is, fluticasone furoate is used in bilateral. Because bilateral has got a rapid onset of action, and it actually, in future, I feel that it may replace budesonide formoterol combination, because it also is superior, improves the symptom control, improves adherence also. So as per few studies, we see that they have tried this in step 3 and 4 of GINA, bilateral fluticasone furoate combination, and they proved that it shows lower need for rescue medications. Probably in future, it may come in the guideline. In the near future, it may come into the guideline. Another one is ultra low is intracateterol with the mometasone. It also has got similar, but studies are few in that. And when we look at step up and step down, I think we'll have to take the equivalent of steroids. Equivalence of steroids. Equivalence means equivalence for budesonide. So fluticasone furoate, we'll have to look at the equivalence, and we'll have to step up or step down. It should be possible, because I have not, I don't have too much of experience. Because I am using it in patchy areas only, not even now I am following the other old combinations. So not much experience, but a few studies have shown that this may be a future replacement for budesonide and format.
All right, thank you, sir. So this year, the GINA guidelines which have just come out, they've also included beclomethasone. So beclomethasone, formoterol combinations have now also been mentioned. So I think time, yes. So as sir has very rightly pointed out, time will tell will tell us how good these combinations are and whether, they're as good as formoterol budesonide. But of course, as of now, they are available and we can use them. So Dr. Parul, very, very important, very contemporary question. A lot of the Europeans, if you look at Professor Mario Cazzola, who is considered one of the biggest names in respiratory OAD therapy, and if you look at the Italian and the French guidelines, they add anticholinergic therapy very early. They don't agree with GINA, and they say that the way bronchodilation should happen is that you should, cover central airways, peripheral airways, and because asthma now, they say, is a disease of the smaller airways, and the smaller airways have a lot of anticholinergic innervation, cholinergic innervation. So giving them LAMA therapy at an early stage might actually be better. And what you are calling difficult asthma, or what is at step 4 asthma, would actually come down to step 2 asthma. They say that your LABA is not the correct medicine there. It should actually be in a LAMA. So at what step do you add LAMA in your clinical practice? Is it always important that you add anticholinergics such as tiotropium or glycopyrronium only at step 5 as is recommended by GINA? Or you do it as the Europeans do, they would add it at step 2. So what is your practical take on that, and how do you review the literature on the addition of anticholinergics in asthma?
Yeah, Dr. Arjun, very, very, very important question, I would say. As far as our, guidelines are concerned, we all know that, GINA recommends the addition of LAMA at step 5. But what is happening is that, many of our patients, uncontrolled or poorly controlled patients, actually, when practically we give it at step 2 or step 3 LAMA, personally in my practice, I add LAMA at step 3 or step 2 also. Sometimes, majority cases I add at step 3. Why? Because I have seen, in fact, there is a good literature to support this also, that when we add LAMA at early stage, our control is better. There are less chances of converting the patient to poor control. There are less chances, better chances that patients within 6 months, they have better FEV1 as compared to the patient having LABA plus, this inhaled corticosteroids. So there are enough number of studies, enough numbers of articles in Lancet, where the studies have been done on tiotropium molecule, where they have added this molecule at step 2 and step 3 and monitored the patient for 48 weeks. They have monitored, and after 12 months they have found that the patient's first hospital admission is delayed by 84 days. So this is one trial which is published in Lancet, and I would really name this trial. It's a group AM Cartesian's original article, which is published in New England Journal of Medicine. They have also studied that in after 6 months of adding this llama at step 2 and step 3, this also has increase in the FEV1 as which is more 12 to 20% more as compared to the ICS plus LABA. So we have two benefits, that there is increase in the FEV1 more at the end of 6 months, and there is delay in the hospital admission of the patient, first hospital admission of the patient at the end of 12 months. So there are enough number of studies to say. So I would suggest that, because here in India we have many patients who are poorly controlled, or there are different reasons for poorly controlled, but I think we should not wait up to step 5. Basically, step 5 is just elongating the uncontrolled asthma. It is better to intervene at the patient at step 2 or step 3. I do personally at step 3, and I add a llama over there, ICS plus LABA plus llama, so that the patient is better controlled. That is my
I
take.
absolutely echo your thoughts over there. So I think guidelines are never laid down in stone. Guidelines are there to kind of tell you a pathway. Every patient is going to be different, and you must phenotype your patients. And that is what we are trying to do today, discuss that there would be a lot of patients, where adding an anticholinergic early might help them, because, what are the way outs? If the patient progresses to step 5 asthma, you're talking about biological therapy and, expensive therapy, which is out of reach for a lot of our patients. So I think early addition of tiotropium or anticholinergic is something which is coming up in a big way. It is being studied in the West in a big way. And I think in the years to come, the guidelines are going to adapt themselves, and we'll see a lot of, papers coming out. So why anticholinergics have not been studied so much in early asthma is because it is difficult to make MDIs with anticholinergics. So the Britishers, were never fond of combining ICS with LAMA, because making this in a MDI format is very, very difficult. So a lot of the trials, which have stemmed from England, they were actually away. They did not talk about ICS LAMA because they were difficult to maintain. So I think in the years to come, we'll have more data regarding this. So another very interesting question for Dr. Moitra. We were talking about vague prescriptions and these polypharmacy and combination of montelukast, levocetirizine. But since it is so, it is in the pen of all of us, is there a specific phenotype of asthma where you need to give montelukast? Is there a specific phenotype of asthma where you need to give combinations of, say, montelukast with levocetirizine, fexofenadine? Are these combinations rational? What kind of a patient should be the ideal patient where actually montelukast has to be used? And what are the risk factors? What are the contraindications of montelukast? And what must a pulmonologist keep in mind before, prescribing this to everyone? These drugs are not as safe as they appear to be. Your thoughts on that, Dr. Moitra?
Yeah, exactly. So as we now know, see, if the asthma is associated with, say, allergic rhinitis, okay, so if it is seasonal or a perennial allergic rhinitis, and in these are the patients, these are the phenotypes of the patients of asthma, where we can think, first of all, we have to treat them with an addition of an intranasal steroids, okay, and along with that intranasal steroids, so there are certain patients who do not do well with intranasal steroids, and also the asthma remains uncontrolled, the rhinitis remains uncontrolled, as we recently know in the area guidelines and all. But the important point to be noted is that this montelukast now has come with a black box warning. Okay, so montelukast has been shown to have the neuropsychiatric side effects. So it is not safe to prescribe the montelukast for a long time. We need to actually see the risk-benefit ratio, whether the patient needs montelukast at all. There's exercise-induced bronchoconstriction, maybe the montelukast before exercise, but other phenotypes, we have to hold on the montelukast, and we should not jump on writing montelukast on every prescriptions. Now let us come to the antihistamines. Okay, if we talk about the antihistamines, again, the antihistamines have a role only in the allergic rhinitis, which is associated with an asthma, if it is not controlled well with the intranasal steroids. And that too, the newer second generation H1 antihistamines, like the fexofenadine, the vilastine, the cetirizine, the levocetirizine, the loratadine, and the soratadine, things like that. But with the advent of the intranasal antihistamines, like the azilastine, when it comes to the combination of the intranasal corticosteroids and given only for like maximum for 1 week or so, it controls the symptoms well. Again, the need for the routine use of the antihistamines goes low. And as I've said, that the combination of this montelukast with this any antihistamines, it is not a rational combination, and more or less, when we're talking about in the context of the asthma control, this does not also place. So it has to be borne in mind. So one should not jump onto the writing a montelukast with sulfonamide, because that is not going to add on to any benefit as per the asthma control goes. It is all again comes back to the ICS-LABA with intranasal steroids, which is allergic rhinitis, and obviously some environmental control and other non-pharmacological aspects is needed to be addressed, to including the patient's inhaler techniques, adherence, compliance, all the stuff which we have been talking.
Absolutely. So that's such a valid point. There's a US FDA black box warning of montelukast that it can lead to higher, percentage of higher chances of suicides. So it is not something that should be taken very, very easily. It is not something that, if you have asthma, the prescription should have these combinations. So choose your patients wisely. As Dr. Moitra has said, if there's a combination, if there is, an element of, say, rhinosinusitis allergies, you can go on, add an anti-allergic. Montelukast at best is an add-on therapy. It will never ever replace ICS-LABA. So pay more emphasis on training the patient, proper usage of ICS-LABA. Ever tried buying a combination of montelukast with levocetrazine? It's 20 rupees, 15 rupees for a single tablet. So to my mind, I think we overdo it quite a bit.
Exactly.
Indu, very, very important question for you. A lot of residents here today, and when they're giving their MD, DNBs, DM exams, all of them, the in question these days, long question is treatable traits in asthma. So what exactly do postgraduates understand by this treatable traits term? What are they supposed to write in their answer sheets very quickly?
Okay. So basically, this is very interesting question according to me. And I feel this asthma management is not just about medication. This is what one should remember. And one size fits all is not the right approach. So basically, it is harmful if there is a discordancy between the airway inflammation and the respiratory symptoms. So for most of the diseases now, we always say that the treatment should be individualized and personalized as per their individual characteristic or the trait. And every individual has their own trait. So there is a nice actually graph which is abbreviated with the A to Z treatable trait, which if you permit, then I'll just take a minute. So A stands for allergic rhinitis, B is for the breathing pattern disorder, which is basically hyperventilation. C is for comorbid COPD, D is for depression, E eosinophilia, F pheno. Then you have your G, which is GERD, so on and so forth. So you have this laryngeal obstruction, then you have depression, smoking, you have your cardiovascular morbidity, you have the Z, which is the Z scores for osteoporosis. So these are certain comorbidities, very common. What we see in our clinical practice is allergic rhinitis, which is very, very common, chronic rhinosinusitis with or without nasal polyposis, and GERD. GERD is again very common. And of course, the emotional and the social needs, which needs to be addressed, So these are certain things, and the treatable traits approach is the best approach in basically good symptom control and in reducing the risk of the exacerbation of the asthma. So I think this will, if a young pulmonologist actually starts his practice, this is what he should remember. This will increase his clinical practice also, I guess.
Excellent. So I think the ABCD is something which is important to remember. So treatable traits are the traits which make asthma control difficult.
Yeah,
so always remember them. Very, very important point. So Rajesh, a very interesting question for you. This is a practical question. We talk about that, as pulmonologists, as good pulmonologists, there is this very thin line between difficult asthma, severe asthma. And we should always, try to find out whether this is true severe asthma or not. So there's a very interesting patient, she's a 48-year-old woman. She is morbidly obese and she has Th2 severe asthma. She is a true patient for biological therapy. And, she fits the bill. Her eosinophil levels are high. She has Th2 asthma. She's morbidly obese. So we sent her to one of the government centers. She cannot afford a biological. So when we sent her to the government center, they said that, your asthma is difficult because you need to lose weight. Now, in order to lose weight, you need to start working out, you need to start moving. She's not able to move because she's so breathless. So this kind of vicious cycle comes into play. So how do you treat these patients? You want to give her a couple of shots of biologics and, maybe her breathlessness gets better and then she starts to lose weight? how would you approach this kind of a patient? Because, in Delhi NCR, a lot of government centers, two government centers are doing trials on biologic therapy. So a lot of our poor patients, who have the need of biological therapy, we send them across to these two couple of centers. The problem there is they would find out a difficult to control asthma phenotype. They would say that this is a treatable trait in this patient and not give the patient a biological therapy. Your take on it? I know it's an abstract question, but what would you do with this super obese patient?
I will try to answer that, Dr. Arjun, in two ways. One is the available evidence-based behind that, and secondly, the hardcore practical sense of that. From your statements, she really fits into that category which requires anti-interleukin-5 treatment. So all the other correctable factors other than the obesity have been taken care of. She has an eosinophil count that very well fits, and she's not able to lose weight. Obviously, she may not be able to exercise and lose weight as long as she doesn't, her asthma doesn't get better. So in a very practical sense, probably go ahead. That's available if she's affording that, or even try to coax the government center to do that, because that's the practical way ahead. That's my practical way. Now, coming to the real theory part of that, yes, in a very rigorous definition sense, she doesn't fit into severe asthma. But then probably I really feel that if some of those factors, modifiable factors, are not getting modified even with the best of attempt, then probably they should go into the definition of severe asthma. Now, the evidence base for that, if I'm not mistaken, the three major trials on benralizumab were Sirocco, Kalima, Zonda. So I don't think they really excluded overweight patients and obese patients. If I'm not mistaken, the average BMI of patients enrolled in the Sirocco was somewhere around 29. So a substantial chunk of them had a BMI more than 30. That's the first part of it. So it's not that just because of obesity, these patients are excluded from biological use or biological trials, even that matter. And secondly, we have some real life papers that are coming up. The one which I actually read was just forgot. I think something like some Anaki or something like that in ERJ Open, which actually looked at the benralizumab response in the real world to obese patients, as well as compared that with the patients in the normal category of BMI. And they found out that the response was not that different between those who were in the obese range, that is 30 to 35 range, and someone in the 25 to 28 range. So these agents do work in obese patients also to a substantial extent that they do work in normal weight patients. So from a evidence point of view, from a practical point of view, I would probably go ahead and post this patient on a biological, because she really requires that.
Even I would do that, but difficult to, convince. Yeah, very difficult. Sure, point very well taken. Ravindran, this one is for you, a very important question. We all know when it comes to respiratory therapy, the most important therapy, as we've been talking today, is devices. And when it comes to devices, the number one selling devices in India are the dry powder inhaler. The part of the country where I practice, if you give an MDI to a patient, that patient is not coming back to you. All they want is a DPI, because MDI is a major stigma in our part of the country. So multiple kind of DPIs are available in our country. And there's this talk now of the newer DPIs that are coming, the preloaded DPIs. A lot of new terms are being introduced wherein, they would come and tell us that this is a high resistant DPI, this is a low resistance DPI. So when you're choosing dry powder inhaler devices in your clinical practice, how do you, choose between these high resistance, low resistance devices? Is there any data to suggest that, one kind of a DPI device is better than another kind of a DPI device? How should a young pulmonologist who's practicing, tread when they're bombarded with so many devices that are available to them?
Dr. Arjun, we know that there are a lot of fancy devices available, and our patients prefer DPI more than MDA. But what I feel is that it's because of poor communication and counseling on the part of the doctor that the patient always prefer DPI, because earlier the DPI they can get it retail. So initial expenditure will be less when compared to an MDI. Even though the total cost is more than MDI, Initial what they spend is only for 30 capsules. So that is why it has become popular. When I prefer a device, I always look for the patient's preference. Number one. Second, patient's type of patients, age of the patients, the patient, and other comorbidities. And third is accessibility and availability of this particular device. We write a fancy one which will not be available in a particular area, means that patient is not going to buy that. That is what I say. And this high resistance, low resistance, I didn't take this into account for my prescription, but we know that when you go to the literature, we find that high resistance needs only low flow rates. So it will be better for elderly patients and very young patients who cannot generate high flow. Whereas healthy individual, young healthy individuals, a low resistance device may be useful because that much of effort they can put. So that is the difference between these two devices. But otherwise, single-use, multi-use devices, they all are different in their cost. And they say that this is the advantage of this particular one and that is the advantage of that particular one. But I don't think that the patient, in a way, benefit out of that. If we tell them correct method of using this device and correct dose of the drug which is delivered, then everything is going to act in the same way. That is my take on that.
All right, sir. So a lot of DPI devices practically more or less are same, but if it's a patient with a low reserve, you would want to use a high resistance device. All right, sir. So Parul ma'am, we were talking about the new term treatable traits. This is a long question. Now another long question, another very important concept that is being asked these days is the comorbidome. So this term comorbidome in COPD, comorbidome in asthma is the in thing now. 5 most common comorbidities that every postgraduate and every practicing physician should look for in patients with asthma in their clinics. Without looking for these 5, no workup should be complete. What do you say are the top 5 in an Indian practice?
Yes, doctor. I think one thing we have to understand that when we are talking of some poor control asthma, difficult to treat asthma, delayed control, I would say these type of things, we should always think about the comorbid situations because it is definitely there. I would say 90% of the patients in our OPDs having difficult to treat asthma have the comorbidities. First number, if I have to give in the clinical practice of mine is it is always rhinitis and sinusitis. Now, the data vary from 50% to 70%. But here, what we find in the OPD and some of the international articles tell that it is as high as 80 to 85% also. So we have to ask the patient about the allergic rhinitis. We have to rule out sinusitis. We have to rule out the allergic traits. We have to rule out the skin allergies. So collectively, we have to treat the patient rather than treating only the asthma because it is as such also one airway, one disease. Second most comorbidity which we found nowadays is, sometimes which is underdiagnosed also is GRD. GRD is a thing which most of the patients, I would say 40 to 50% patient have, maybe because of stress, maybe because of food patterns, maybe because of anxiety, which is again a very, very important comorbidity, and anxiety and GRD and uncontrolled asthma, go together. Anxiety, depression, and sort of, gastritis go together. So we have to clinically judge. It's very difficult to practically do 24-hour pH monitoring that nobody is doing, I think, in the OPD, and I don't recommend that. But clinically, we have to ask about the symptoms of gastritis, symptoms of GRD, and that way we have to add, a combination of PPI with Domsal or PPI so that is comfortable. Third most common comorbidity which I want to mention here is definitely obesity. See, why I'm putting it above other comorbidity, definitely there is depression, there is infection, other comorbidities, there is, anxiety. there is always a hormonal, there may be hormonal disturbance, there may be some different type of bacterial infection. All these are different comorbidities, but obesity or obstructive sleep apnea or uncontrolled weight gain is the most common thing which is happening in this era of increasing NCDs. We are seeing so many childhood obesities. There is increase in the obesity in the middle age also. So I would say that because of the increase in weight gain, there is change in the phenotype of the asthma. And change in the phenotype of the asthma, there is a definitely increase in the symptoms. And the same way as we discussed, the last speaker discussed, that it is very important to at least have a 10% of weight loss so that the OSA symptoms reduce and definitely we get a better control of asthma. So obesity, if BMI is high and then patient, if you suspect OSA, you have to subject the patient for sleep study and definitely diagnose and simultaneously treat the OSA as well as asthma, and along with the weight loss therapy and diet therapy, so that patient is holistically treated. What we are finding nowadays is also because of the maybe because of the smoking, which is very much prominent in the society. Maybe it is active smoking or passive smoking. I would not say it as comorbidity, but it is a habit and creating a coexistence of the OLDs or obstructive lung diseases, which is again a different factor which has to be controlled, and smoking has to be avoided. Smoking cessation therapy also needs to be given. If 5 number I have to give, I will give to the psychological issues like anxiety, depression, which is definitely causing a lot of problem in understanding of the disease, in the compliance of the therapy, in the monitoring of the patient, in acceptance of the treatment, and also the mood disturbances, which causes again hormonal disturbances, which causes ultimately the poor control of asthma. So these are the common things which are definitely increasing in the society, and asthma is not a single entity, and especially difficult to control. Asthma is not a single entity. 90% it is definitely associated with any of the comorbid conditions. And last thing, that asthma also has, difficult to treat asthma also has comorbid chronic infections, maybe more of moraxella, maybe of chlamydia, that we should not forget, that we should definitely go for the sputum culture of these patients. And these type of chronic infections should be treated well according to the evidence and according to the culture sensitivity reports. So I think this is all about the topmost 5 comorbidities, and we have to broaden our index of suspicion to pick up this. It is just rather than saying and increasing the dose of inhaled steroids and increasing the dose of all these single treatment, rather than thinking about better treatment also.
I think fantastically well put. And I think all postgraduates must keep these 5 or 6 pointers. And all patients with your OADs, obstructive airways diseases, please always look for these comorbidities. And you would see that 90% of your patients in your OPD would have these difficult to control asthma treatable traits or these comorbidities out of the comorbidome. So look out for them. Dr. Moitra, when we talk about asthma control, everyone talks about, very common answer, very common line written in the GINA guidelines, that avoid the triggers. How do you avoid these triggers? The triggers are ubiquitous. They are everywhere. So writing it in an answer sheet, is different. Doing it in clinical practice is another thing altogether. So how does one avoid these triggers? How does one search these triggers? I always find this very difficult to do in clinical practice. Very simple pointers, when you are dusting, obviously use a mask, try not to do it. But apart from that, 5 or 6 pointers that you want to give to the PGs and the young physicians, what to do in real life settings.
Exactly. Thank you, Dr. Arjun. Yeah. So now we know that when we talk about the asthma, we again now, so this is the era when this is basically an era of the epithelium. The epithelial dysfunctional disease, which is an asthma. Okay. So now our entire outlook is changing. And with this recent area medal hypothesis and all, we find that this is because of the exposomes, which we talk about, which is there in the environment, which is actually triggering the epithelium to fire in such a way so that this leads on to the chronic airway inflammation. These exposomes have to be taken into consideration, and they have to be address to. So what we can do? So what are these exposomes which are mainly important in case of the asthma triggers? We know the common are the allergens, that is the house dust mite. So how do you avoid an house dust mite? So this is not basically that when you're dusting, you will always sneeze, you will always have a cough, you will always have some chest tightness. So that's always there. But this basically is the house dust mite avoidance measures, like which they are basically there. They're within this mites grow within the pillows, within the mattresses, and there we need to address that. There's a washing that pillows and mattress covers as 3 times a week in hot water, or using and some there's allergen and some which prevents the allergens to come up. We have those some allergen covers, the bed sheets, and these are there. And most important is the relative humidity in a particular indoor environment. So these types, if the relative humidity is more than 50%. So maybe the like keeping the doors and windows open, having enough sunlight, right? So that to reduce the relative humidity, and that reduces less than 50%. Someone said that we need to use a dehumidifier. Well, that's a costly affair. If someone can use that, someone may use it, but that is very, very important. This is one of the triggers. The next trigger is very important is the cockroaches. Okay, we know the cockroach allergens are the very important triggers for the asthma exacerbations and the continuation of the airway constriction and remodeling. So very, very important, always have an integrated pest management done in the house, so which will help to reduce the cockroaches, because otherwise it's very difficult to get rid of the cockroaches. Third, obviously, if there's a known trigger with some pollens, in the seasonal pollens, obviously we say that in those particular months, and don't go out in the mornings and the evenings, keep the windows and the doors closed in the mornings and the evenings, things so that when the pollen load is high, usually at that time we are more protected indoors. Having an AC also helps. Then comes your these pets. Obviously, this is a difficult proposition. We know that if there's a pet in the house, you cannot get rid of the pet. It is a part of the. It is a member. The cat or dog is a member of the family. Well, for that matter, well, now like if that's not preventing them to get into the bed, washing them regularly is all that you can do. So now they have come up with the cat allergen immunotherapy. Well, that is not yet available in India, but that is available in Europe, and that is shown to be quite credible. These are the important triggers. Now, apart from that, there are some other triggers which are very difficult to control, like the diesel exhaust particles, the automobile, the pollutants. Okay, so these are the ones which is very, very difficult. You cannot do much about it. So if you are having a proximity to a main road, and that is usually it's one of the factor which actually increases or makes the asthma poorly controlled. So, well, what you can do about it, this is no practical. If you have an option, you can change. You can go to some other places. Give this option. Talk this with the patients, and then try to understand that. So no matter if the patient is like just the house is on a main road with lots of vehicles. So no matter what you give, so this patient will go on having a really poor asthma control. So just stick to them. And so these are the very important things which you can discuss with the patient. These are some recommendations which you can give. And also there's a mold spores. Okay, there's another triggers. So if there's a dampness in the house, try to get the move of the dampness. Okay, so this is important to reduce the mold concentration indoors. These are some of the practical, inexpensive, you can tell this patient. These advices you can give the patient. And this goes a very long way in achieving the asthma control. So these are some things which has to be borne in mind while talking to the patients.
Sure, I think very practical, talking about all the more major ones. And I think where I practice Delhi, the most important question is whether to buy an air purifier or not. So I think the answer now, every year our answer is different. 5 years back it was yes, you can buy one. Now the answer is buy one for each room, buy one for your office and buy one for your car. So our practice is totally different. So all of us, all I invite all of you to come to Delhi during November and December for a couple of days. Bring your respirator masks and see what we go through every year. So, changing gears, Indu, this is very important because a lot of questions we are getting on this. And this is something that, the real role is always being very, I don't know if shady is the correct word, but what is the correct role of immunotherapy in asthma? When should patients actually undergo allergy testing? Is it for all asthmatics? When do you do it in your clinical practice? What is the evidence regarding allergy testing in patients with asthma? Should you actually be doing it at all? And if at all you plan to do it and say someone, is a candidate for immunotherapy, what kind of a patient is a candidate for immunotherapy and what kind of immunotherapy? I know loads of questions, so quick answers.
So this is the most difficult question, I feel, because it's the most popular thing patients ask us, should we go for the allergy test? So basically, the presence of the atopy increases the probability that there is an atopic asthma, allergic asthma, but it is not necessarily sure that the allergen which is present is causing the respiratory symptoms. Okay, so it can be associated with atopic dermatitis, eczema. It could be associated with allergic rhinitis. So the presence of the skin prick test or the presence of whatever specific IgE in the serum, the allergen sensitization should be correlated with the clinical history and the respiratory symptoms of the patient. And of course, it is done by two ways, which is the skin prick test and the specific IgE test in the serum. And what I said, it should be correlated with the patient's history. So I personally don't recommend it too much. I don't feel that it is necessary, to be honest. Like in asthma per se, I don't know how is the opinion of the others. And allergen immunotherapy, again, there are very few people who are doing it. So when I'm not writing the allergy test too much, only when the person has a continuous exposure to the particular allergen, like patients having pets at home. The recent patient had a cat exposure, like cat at the home, and his symptoms were not actually typically because of the cat exposure, but he had himself done the allergy test for the cat epithelium and dander, which came out significantly positive. But patient didn't actually, as sir said, the cat is still there. There is no avoidance of the cats. And so if for this patient, if the patient was not under control with the asthma medication, or if the patient was, requiring medium to high dose of the steroids along with LABA, then I would probably ask the patient to go for the allergen immunotherapy. So again, allergen immunotherapy has an add-on benefit in the patients who have clinically relevant sensitization to the aeroallergens. Now it is done by two approaches, which is sublingual, and sublingual is basically tablet or drops under the tongue, and there is a subcutaneous route. But again, the studies are done on the mild asthmatics. So if you are going for any allergen immunotherapy, you have to discuss with the patient that there are potential benefits versus the risk, which is very, very serious adverse reactions and anaphylactic reactions, which are possible because of the subcutaneous immunotherapy. So these things should be discussed. And of course, the extracts, one has to use the standard extracts, and the person who is doing should be well trained in carrying out the allergy test and in immunotherapy. So these things should be explained to the patient. Of course, the duration is 3 to 5 years. So that is also very time consuming. Patient should be ready for that kind of the treatment. So all these things should be discussed before the start of any advice on the allergy test or the immunotherapy.
Very important, very, very well taken. As I think the most important matter here is whenever you're prescribing immunotherapy, people should never be prescribed immunotherapy for severe asthma or asthma where the lung functions are low, where the patient is actually sick. So immunotherapy is an add-on when the patient is not too bad. There is a concomitant allergic component in the form of a rhinosinusitis. The patient is educated enough to carry on the treatment for 3 to 5 years.
Right.
So there are a lot of contraindications to doing it. So indiscriminately doing allergy tests in all asthmatics, I think, Indu, you've raised a very important point there, is absolutely not justified. These tests are expensive. Obviously, if there's a trigger, which needs to be avoided, which needs to be, again, kind of pointed out to the patient that, this is the trigger and you need to avoid this, boss. Probably in those patients, we would go ahead and do, all kinds of allergy tests. And Indu has
also, there is one very important point that it should always be done. The immunotherapy should be done when the asthma is under control and there is a lowest risk of the exacerbation. Only then it should be done. Otherwise, there are those serious adverse reactions which are possible.
Sure. And you talked about, allergy testing. Now, Rajesh, coming to you, multiple allergy tests are available, skin prick, blood-based. A very important test that keeps coming to our OPDs is this Top test. Now, what is this Top test? Is it a substitute for the skin prick test? How do you interpret these tests?
Yeah, nice, Arjun, for bringing up that particular topic now.
And also, I'll just add one
I
more
heard.
question. A lot of patients come with these food allergy tests, where you have these components. I don't know in Kerala what they do. In this part of the country, they would come with this 5-page report where every possible thing that you can think of, right from peanuts to chocolates to wheat to rice to milk, then an allergy test, they'll carry this report. So how valid is this? Should this be done at all?
Okay. The first part of it, the Padiatop, at a personal level, I am not a big fan of that, so that bias might come out in my answers. I am sorry for that. But then theoretically, it's one of those serological tests for detecting allergen-specific IgE. I think that's being marketed by Thermo Fisher. Under the name, it's actually an immunocap. So it's a higher generation RAS test, immunocap technique. It's being used for detecting allergen-specific IgE. The theoretical advantages could be that it's a non-invasive test. A miniature amount of blood only, serum is only required. There is no risk of anaphylaxis that can happen with skin prick test and so on and so forth. But in a practical sense, sensitivity is slightly less than a skin prick test, and it's much more expensive than a skin prick test. So if you are really going to contemplate an allergies test, I would still go ahead with your time-honored gold standard skin prick test. So that's the first part of your question. And the second part regarding food allergy, I probably would disregard many of those standardized food allergy test reports for multiple reasons. First of all, I'm a very firm believer that most of the allergic triggers in allergic asthma or allergic rhinitis, or for that matter, be in any allergic disease, it's the air allergens rather than the food allergens. The food allergy holds an important role in the minority of asthmatics or other allergic diseases. That's my personal feel. And secondly, if you really need to detect food allergy, you need to go ahead with the so-called double-blind placebo-controlled food challenge test, which is very cumbersome and very difficult to perform. It requires weeks of avoidance of one food and gradual reintroduction of specific agents and so on and so forth. So the skin prick test, I don't think it's a labeled test for, or skin prick test or even the various serological tests, I don't think they are that labeled for food allergy at all. And if you have a clear-cut documentation of clear-cut anaphylactic reaction or some specific allergic manifestation consistently to a specific foodstuff, then probably go ahead and avoid that. Otherwise, I probably won't go ahead with such a believing such a serological or skin prick test for a food allergy.
What are the three biggest villains in Kerala? In Delhi, it is curd, milk, banana, and also rice.
Okay, here a lot of people come up with chocolates and such stuff. One is documented reaction to chocolates, so a true probable food allergy, and many of those stereotyped tests come back with this one and dal. Many of those come with dal positivity and sometimes milk.
So yeah, very rightly said. These tests need to be thrown in the trash bin. We are talking about asthma
Arjun,
here. Allergens is something that you should. Sure,
Arjun,
sir.
can I add something? Yeah,
Oh, please.
I just want to, yeah. Okay, I thought I'll just add a point over here, is that when we talk about Padiatop, okay, we should be sure that what we're talking about. This Padiatop is not the replacement of a skin prick test, because Padiatop only says whether there's atopy, yes or no. Okay.
Yes.
So if you are in doubt about the patient having an allergic disease, rather than going for total IgE, you go in for the Padiatop. But if you're taking a very good detailed history of the patient, you do not need a Padiatop at all. Okay, so skin prick test is the gold standard test. That is one point is over here. Second thing is that another very, very important point which needs to be highlighted is that all these tests which is being done, whether we do a skin prick test or whether we do a specific IgE test, they only merely says the presence of a free IgE against that particular item in the blood or a mast cell bound IgE on the mast cells. So having only an IgE is an immunological phenomenon. It is only called sensitization. As Dr. Indu has very rightly said, sensitization does not entail a clinical disease. It's an immunological phenomenon. So it has to be clinically relevant. So you again go back, sit with the patient and see whether these triggers are there in the patient's environment, and then you actually correlate with the history, then you say it's an allergy. Otherwise, it's not an allergy. And regarding the food, if It's still, we're fortunate to have a very low incidence of food allergy in our country, thanks to our lifestyle, but it's changing. So food allergy is not an important thing to be considered while evaluating asthma or a rhinitis or other any like the allergic airway diseases. So if we do a test, even for a normal individual, will show the positivity to many of the items, but those has no clinical significance. They only confuse the patient, confuse the treating physician, and makes the things more worse. So it's better to avoid the food allergy testing if it is not needed. Otherwise, one can go in very selected cases for open food challenges. Okay, but that is separate, totally separate ballgame.
Sure. Point very well taken. Thank you, sir. So this one is for Ravindra, sir. And I think, whenever you talk about when you talk about difficult asthma, I've got 40 questions, from the audience, which are all about severe asthma, all about biologics. So this talk today is about difficult asthma. We are not talking about severe asthma today, but because I have more than 40 questions on biologics that have already been asked, Ravindran sir, just to sum it up very quickly, because I think you would be the best person for do this. You've seen the complete era of, biologicals being introduced. And, there's this general tendency that we as Indian pulmonologists shy away from using biologicals. Most of our rheumatology colleagues, they tell us that, when biologics were launched in India for rheumatological diseases, they actually welcomed it with open arms. And because they used it so well, the prices dropped very, very rapidly. So, things like rituximab, which were terribly expensive when we were residents, are now not out of the common man's pocket. On the other hand, drugs like mepolizumab, benralizumab, we as pulmonologists somehow tend to shy away from these drugs. So if cost was not a constraint, sir, would you use biologics in more of your patients? What is your cutoff? At that point, you would want to use a biologic in a patient with difficult to control asthma, or what is your definition of that severe asthma where a biologic is actually required?
Actually, Dr. Arjun, I will not use this in difficult control asthma, but there is an entity of therapy resistant asthma. This is very low in number, 3%, 3 to 4%. That group of patients may be considered for biologicals. So such patients should be endotyped for an eosinophilic asthma or non-eosinophilic asthma. And based on that, we can plan a biological treatment, because that is the only way possible for that particular group of patients. Need not consider difficult asthma or severe asthma where there are innumerable number of causes which we can revert easily without going for a biological. So blindly following a biological is not my way. But this particular group, small group of patients where we cannot control with the optimum management with the available drugs, then we will have to plan for this. Very easy, because we have to look at eosinophils, IgE, all those things, and we can identify which type of inflammation these patients has got, and we can move on to that line of management. That is my policy on that.
Sure.
Dr. Arjun, can I just add one thing to that?
Please,
Not
sir,
add,
please,
but
please go ahead.
the threshold. At a personal level, I feel most of those guidelines say that if the patient is getting systemic steroid dependent, that time try biologic as a first option rather than utilizing a systemic steroid. There are upcoming evidences which say that around 4 or more short spurts of steroids per year do almost the same degree of harm as even a smaller dose of sustained steroids. So if someone has passed all those checks like compliance and inhaler technique and comorbidities taken care and still requires exacerbations requiring frequent systemic steroid spurts, then probably I will offer biologic agents to him if he fits into that criteria for biologics.
Sure. I think our thresholds are also going down now. And I think we need to not look at biologics as villains, They are good drugs in the rightly chosen patients. I'm not saying that they need to be used indiscriminately, but I think patients who have a terrible life because of their asthma, when they have actual Th2 asthma, where everything else is not working, it makes absolute sense to use them in the right patients. Now, coming back to Parul, ma'am, since you are a professor and work in a medical college, all long questions are for you. So this is another long
Yes.
question that PGs are, supposed to answer. And this is something which is the in thing. So many talks on this, so many seminars, remission in asthma. So our rheumatology colleagues are talking about, they were talking about remission in rheumatoid arthritis, remission in sarcoidosis 30 years back. We as pulmonologists have never talked about remissions in asthma. Now, this definition is being something which is being talked about very commonly. How do you define an asthma remission? Do you think it is possible? If at all, how?
Yeah, thank you once again. See, basically, it's actually a matter of happiness that we are not talking about remission, I would say. See, with the advanced drugs, which are disease-modifying drugs, which are the anti-inflammatory drugs now in the market, and with an ability to control inflammation in a better way and in a more persistent and effective way, we can now think about remission. That is first point. So to define remission is, there is again there are two things. One is clinical remission and second is, complete remission. So if we define remission, then it has to have, absence of asthma related symptoms, no systemic steroids for the treatment of asthma, no exacerbation, optimization and stabilization of lung function. And of course, if we want to have a complete remission, it is associated with decreased hyperresponsiveness and also the decrease in the bronchial inflammation. So all these things collectively to be monitored for 12 months. And for 12 months, you should not have all these things. Means no exacerbation, no use of steroids, not admission, no treatment, absence of asthma-related symptoms. All these things, along with stable lung function, it is important to define any patient as clinical remission. But what is happening? See, why this is we are talking is because now we have the disease modifying drug, what we call it as disease modifying anti-asthmatic drugs, that is DMAADS. Now internationally people are talking about this remission because they have somewhere found that over the time using these drugs, as we use anti-inflammatory, we use lama, we use ICS, these all things have been able to maintain the decrease in the inflammation, or I would say they can reverse the inflammation for a long time, which may be 1 year, maybe 2 years, and it is possible to document it also. And it is the fact that the drugs utilized are better than as they were previous. Again, there is always a chance, always now availability to check the phenotyping also, that what type of asthma it is there. And also there is a international consensus. In fact, there are almost 5 definitions of remission according to different guidelines. I would just name the guidelines, that is practical guidelines for asthma management, that is PGM, then severe asthma network, that is SANI Delphi. There is a guideline of American Thoracic Society which has all these things, but additional to that they include the ACT score also, that as if apart from the points which we discussed above that, if we have the ACT score of more than 20 or AIR Q score of less than 2, then that is also one of the point to be considered in remission. And also the symptoms requiring one-time reliever therapy no more than not more than once a month. That these are the 2 additional points which are included in ATS work group clinical remission guidelines. They also consider one point which is related to school, means should be no missing of work or school more than 12 months. So these 3 points, additional to the other points what we discussed, are the points which are included in the ATS definition. There are other definitions also. Many of the definitions includes ACT score of more than 20, along with other factors which we have already discussed. But in short, what I feel that remission is possible. Remission is possible because of the new drugs, because of the new inventions, or I would say new delivery. The delivery system is also getting better. Like we have the auto health we have the better coordination devices, we have the better delivery, we have better understanding of the phenotypes, we have the biopsies also telling whether it is neutrophilic or eosinophilic. So somewhere we have been able to understand whether it is atopy or not, whether there are raised interleukins or not. So we have somewhere the better understanding of the genotypes also, and the pathophysiology also, and the tissue diagnosis along with the biopsy also. So I think that is the reason why we are not now able to talk about remission. See, I think that remission definition also will change time to time. As we grow in our inventions, we grow in understanding. Today, the definition has all these 4 points. Some definitions have 6 points. Some definition have 5 points. But all the association across globe are now talking about remission, which is possible.
So very, very important point. And as Madam has pointed out, there is no clear-cut definition. So if you see remission in rheumatic diseases, they would talk about a clinical score, they would talk about lab parameters. So same is the issue with asthma. So it is still work under progress, but this is something that we are looking forward to. And as postgraduates, whoever, are the residents here today, please be prepared for this very important questions you are going to be asked this. So, now the trend towards non-pharmacological therapy is something which does help a lot of our patients. As physicians, we must not always talk about drugs. So in COPD, we've always talked about non-pharmacological management, whether it is oxygen, pulmonary rehab, use of NIV, vaccination. So what is the role of non-pharmacological management in patients with difficult to control asthma, if at all there is, Dr. Moitra?
Yeah, Dr. Arjun, I would again fall back upon the same thing that is I was talking about. We all need to understand that to have a better asthma control, we need to control the entire environment in which the patient is there, including the lifestyle and all. So this is all epithelium to type disease. So the non-pharmacological management here we will talk about. Definitely we need to talk about the lifestyle management. This is very, very important. Having a healthy lifestyle, having enough sunlight exposure, doing regular physical activity, the diet, which is very important, having lots of fruits and vegetables and milk in the diet, leaving the smoking. So no smoking and all those, whether it is an active or passive, difficult to have. And these are very important non-pharmacological measures which needs to be taken into account. And obviously, like when we talk about anxiety and depression, which is one of the important factors which leads to poor asthma control. So there needs to have and psychological help with maybe the CBT and other therapies where there is, and these are important. And obviously nowadays we talk about something and like this meditation, okay, the yoga, which is just coming up, the breathing techniques. And these are all the non-pharmacological measures which we usually mention that, well, when we talk of the patient, we take the patient in the entirety in which the patient in environment and in the subject. Should not be a particular vision about a particular system, should be entire like in one health concept, which we all talk about. And very shortly, well, those patients who can be benefited by the allergen immunotherapy, please choose those patients and properly and give them the benefit of allergen immunotherapy with the FEV1 more than 70%, not having an exacerbation in the previous 1 year. Because we know immunotherapy is the only disease-modifying treatment which can have an impact on the entire disease per se. So all these measures are important, but has to be taken into unison and has to be applied along with the pharmacotherapy, which really, really goes a long way in controlling the disease in a particular patient.
Sure. So we must not just look at the drugs. Asthma is way beyond drugs, and we always need to take those factors into account. Point very well taken. So Indu GINA guidelines 2024 were out 1 week back. What are the salient newer features in GINA 2024? Is there anything new? What are those 5-6 new points that we must, now know about the GINA 2024? What are the new changes? You need to unmute, Indu.
Yeah.
COVID,
So,
we have forgotten which muting, non-mute, so it's been long, yeah.
Correct. So GINA 24, long guidelines. But basically, see, it is focusing on the peak expiratory flow meter in the diagnosis of asthma, where the spirometer is not accessible. So in many parts of the country, still we don't have the PFT. So they are saying, instead of depending on the symptoms alone, do a peak flow meter. Second, they are talking about the cough variant asthma, which also behaves like asthma, but we don't have the variability in that. And the therapy basically for cough variant asthma is the ICS containing therapy. And when we stop the ICS, the cough can again come back. So one focuses on that. Then they're talking about LAMA, that the exacerbations are less when you're adding a LAMA to a ICS LAMA in a severe obstruction patient, and adding early reduces the number of exacerbation. So that is one. Then the focus is on the pulmonary rehab also in the patients where there is severe obstruction and in the patient where there is a fixed airway obstruction. So it improves the exercise capacity, it improves the quality of life of the patient. So pulmonary rehab is most important. Then in the treatment wise, it focuses on that the asthma management is not just about medications. You have to look for the inhaler technique and adherence in every visit. And of course, difficult to treat asthma can be effectively managed when you're looking at all these things. And severe asthma, there is a role of biologics over there. And remission is possible when with the biologics in severe asthma. So that is also one point. And of course, there are others also, like the role of the investigation, the biomarkers, basically, the role of FeNO in the severe asthma. So basically, FeNO identifies the airway inflammation. It also tells us about which biologic to choose and the role of the FeNO in the, it also, so high FeNO tells us about the airway inflammation. The FeNO levels are high and it tells us that the patient is going to get into the asthma attack or the poor symptom control. They are telling about the role of the FeNO in choosing the right biologic, as well as telling us about the response to omalizumab and the anti-IL-13 therapy. So these are few pointers, and of course the asthma education is most important. You have to remove the fear of asthma from the patient's mind. There is a stigma when you tell asthma, and the patient immediately will tell that, okay, in the childhood it was told that we don't have asthma, it is bronchitis or it is an allergic problem. So when you're removing that asthma fear from the patient's mind, your 80% of the job is done, and the rest is the treatment if you're doing it optimizing correctly. So the focus is on the asthma management, empowering the patient themselves in their treatment. So in my practice, if I would say, I usually tell that if I know my name properly, you should know your disease name properly, So like if it is asthma, it is asthma. You can choose different names. You can choose an allergic problem for that. You can call it allergic bronchitis. So this is how the counseling goes. Makes it easier for the patient in one sentence. Decide your own names, but this is what the medical term is. So these are certain guidelines. And of course, they're talking about comorbidities and the modifiable risk factors needs to be addressed, and the social and the emotional needs to be also looked after to effectively manage asthma. Yeah.
Sure. So they're very, very composite, the newer guidelines. I would want the PGs to look at the severe asthma guidelines that have come, as an attachment to the GINA guidelines. And also, the step up, step down tables now talk about beclomethasone as well. So it's not just formoterol budesonide. So that is something new. Most of the points have been highlighted by Indu. So I think a lot of questions we've already covered. Most of the questions that I've got are on severe asthma. Specifically, we are talking about difficult to control asthma here today, which is the most important phenotype of asthma that you're going to see in your clinical practice. Ravindra sir very rightly said, severe asthma, treatment-resistant asthma is 3% of total asthma. In a pulmonology practice, difficult to control asthma is something which you would see more often. However, as was expected, most of the questions are on biologics and, what kind of biologics, when to choose, when to start. So I think I'd request Amita ma'am to have a separate talk on severe asthma, where we can discuss about biologics, bronchial thermoplasty, what role of azithromycin, TH1, TH2 asthma. So, this is beyond the purview of today's webinar. It's an important topic. We need to do it at a later stage. So before I ask Rajesh to sum it up, just a couple of questions I'll take up. One is, because this question has come so often, 3 or 4 times. what are the management options for a TH1 asthma or a TH2 low asthma? I'll answer this. So we are talking about difficult to control asthma. We are not talking about severe asthma today. However, because this has been asked, TH1 asthma is nothing but TH2 low asthma. So you understand what I'm trying to say? It is now said that all severe asthma or treatment-resistant asthma is basically by nature eosinophilic asthma. Unfortunately, by giving them a lot of steroids, because of steroids, the patients develop what is known as airway neutrophilia. And because of the immunosuppression by steroids, a lot of patients will develop neutrophilia in the airways and chronic airway inflammation due to bacterial infections. So now it is said that the term TH1 asthma is not correct. It should be TH2 asthma and TH2 low asthma. So the mother molecule of all severe asthma is now said to be eosinophil. And the treatment options for non-TH2 asthma are not very clear, but the most important treatment option for non-TH2 asthma is to not load them with steroids. Now, you can do whatever you want to do. You can give them long-term doxycycline. You can give them long-term azithromycin. However, the crux of the matter is, if it is non-TH2 asthma, don't give them steroids. The steroids have already caused the neutrophilia. The steroids have already caused airway remodeling, airway inflammation, repeated infections. So in one line, the treatment of non-TH2 asthma is not steroids, right? Another question that has been asked very commonly is difference between fluticasone and budesonide. So fluticasone is a more potent steroid. In asthma, it really does not make any difference because most of the asthmatics are younger patients. So in a younger patient, I would not really bother because both the steroids are efficacious. Fluticasone is said to be more effective at the receptor level. So I would shy away from using fluticasone in patients who are predisposed to repeated chest infections, the elderly with COPD. In those patients, budesonide is a much softer steroid. However, in the younger asthmatics, fluticasone versus budesonide, it makes no difference, right? So I think majority of the questions we have answered directly or indirectly. I'm saying again, I'm not taking up questions on severe asthma because we'll be sitting all night otherwise. So before I just end this, I want Rajesh to summarize what we have discussed today. What are the 5 most important takeaway points, Rajesh, that physicians who are attending today and the PGs who are attending today should go home with?
Okay. We'll just put it across this way. Number 1, asthma is the most common chronic respiratory disease that we encounter as practicing pulmonologists. Number 2, a substantial chunk of asthma cases are easy to diagnose, easy to treat if you follow simple clinical principles aided by a very small battery of tests and a very small number of molecules, pharmacological molecules. 3, evaluation and treatment of asthma requires a systematic approach. The proper clinic-based diagnosis supported by, say, limited battery of tests like spirometry, ruling out alternate diagnosis, such things. Giving the proper treatment, including inhalers, ensuring compliance, ensuring the correct inhaler technique, look for comorbidities, and give the proper quanta of treatment. 4th, there are a small percentage of asthmatics, like Ravindra sir said, say 3%, maybe I will say 5%. So that proportion are probably truly therapy resistant or would qualify for the definition of severe asthma. So they require a more focused approach, including phenotyping and specialized therapy. And last, but probably the most important message, which I feel would be that we need to set up specialized asthma clinics, severe asthma clinics. Because the advantage is that, yes, they bring to us a screened group of asthmatics who are actually difficult to treat. All of them may not require phenotyping. All of them may not require biologic therapy or other high-end therapy like thermoplasty. But the fact is that we get a screened population. We get to spend more time with that. We look at those basic aspects in a much more focused way, including the diagnosis, including the inhaler technique. We tend to get more time spending with the patient. So in a busy OPD practice, many of the simple asthmatics are actually labeled as difficult to treat asthmatics or even severe asthmatics. That's one spectrum of it. So that can be overcome in this specialized asthma clinics. In busy OPD practice, many of those severe asthmatics who would actually benefit from biologics are actually not picked up and treated because of the lack of time, because these patients need a lot of time for picking up counseling, phenotypic, and all those things. So if there's a specialist asthma clinic, we dedicate more time to this difficult to treat asthmatics, pick up the severe ones, and probably those who really deserve get the higher treatment. So specialized asthma clinic setting up would be one message that I can give at the end of this particular webinar. Thank you,
Thank you
Arjun.
so much, Rajesh. Thank you for summing it up so well. And I think that's a point very well taken. And, setting up an asthma clinic has actually helped us in a big way. And it does make you more focused. You tend to see these patients in a better way. So that is a very, very good suggestion. So I think we've tried to do justice to most of the questions that were asked. And I could not thank my panel enough for being so generous with their time. Ravindran sir, always a pleasure interacting with you. Always an honor, sir. Thank you so much for sparing out time. Ravindran sir was almost to be my DM examiner, and we were terrified when he was coming. But I've interacted with him so many times after that, and I think there was no reason for us to be terrified. Thank you, sir, for being so great, for being so understanding always. Dr. Moitra, Parul ma'am, Rajesh, Indu, all everyone, thank you so much for being so patient, for all your efforts, all your time. I know it's very late. Everyone is hungry now. So with that, I again thank Amita ma'am, Rajadhar sir, Sandeep Salvi sir for this initiative, team from Lupin for supporting all of us. So signing off on difficult asthma, and hopefully Amita ma'am would give us a chance again to talk about severe asthma next time, right?
So Arjun, just one thing.
Yeah.
You were a really nice moderator. You included everybody and covered all the questions so nicely. And I think you should take up severe asthma. Just let's talk to Dr. Amita. Good luck.
I completely agree for the best. I one of the best moderatorship I have seen. Very
Thank you, ma'am.
nice.
Thank you so much. Thank you.
And brilliant,
Really
Arjun.
true. Really.
As ever.
Thank you, Dr. Arjun and all the panelists.
Yeah.
Thank you.
Yeah.
Thank
for
you.
interacting.
Thank you so much.
Thank you.
everyone.
Thank
Good
you.
night.
Good night.
Thank you so much for your
Bye.
time.
Bye.
Good night.
Good
night.
Thank you.
Bye.
Bye-bye.
Thank you, everyone.
Thank you, sir. So now with your permission, can I end today's meeting?
Yes, Kev.
Yeah, thank you once again, everyone, for joining today's sessions. I thanks all the delegates and doctors too, who have joined over the attendance link. Thanks again, everyone. Have a great evening to all. So now from here, we are closing today's meeting. Thank you.